Hello, and welcome to the ACR Journals on Air podcast. I'm your host, Vicky Shamagam. One of the primary goals in managing adult patients with lupus is to achieve either remission or low disease activity. But what about kids? The manuscript we will discuss today is Improving Outcomes of Pediatric Lupus Care Delivery with Provider Goal-Setting Activities and Multidisciplinary Care Models. It was recently published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes from today. I'm excited to be joined by the manuscript's first author, Dr. Joyce Chang. Dr. Chang completed her undergraduate degree at Harvard and then medical school at the University of Pennsylvania, followed by internship, residency, and fellowship at the Children's Hospital of Philadelphia, lovingly known by kids worldwide as CHOP. She is currently an assistant professor of pediatrics at Harvard Medical School and an attending physician at the Boston Children's Hospital. Dr. Chang has been an incredibly successful junior investigator. She was awarded the first Childhood Arthritis and Rheumatology Research Alliance, or CARA, Health Equity Research Grant to identify neighborhood-level factors associated with differential lupus outcomes. And she also co-leads efforts funded by the US CDC to understand the contribution of social determinants of health disparities on disease activity and damage in the CARA Lupus Registry. Her work is supported by an NIH K23 award, and she was awarded the Lupus Foundation of America's Mary Betty Stevens Young Investigator Prize in 2022, a massive achievement in recognition of her contributions to lupus research. Welcome to the show, Joyce.
Thanks, Vicky, for the very kind introduction, and I'm very happy to be here today.
So to get us started today, I wondered if you could orient our listeners a little bit to the work you and the CHOP team have been doing to establish a composite index of pediatric lupus care metrics, in particular the Pediatric Lupus Care Index, or PLCI. What is the PLCI, and how have you encouraged its adoption in the pediatric community?
So I really have to give credit to Dr. Sandy Burnham. He was, my quality improvement mentor and one of my rheumatology mentors during training. And he was the one who thought of creating a composite index as a way for us to benchmark, the quality of care that we were providing to our patients, both as individual providers and as an entire practice. Because there are just a lot of things you have to remember and keep track of when taking care of children with lupus. So you can't really just fly by the seat of your pants. And so the things that went into the PLCI were care processes that everyone, for the most part, agreed were important to do, but also measurable. And so they were all related to one of three concepts: routine assessment of disease control, minimizing disease and treatment-related comorbidity, and population management. So part of the reason for publishing this manuscript was really to show the pediatric community that measurement of care processes and care quality can be automated and sort of built into the EHR, making adoption a little bit more feasible.
Mm-hmm. And your team at CHOP also developed a multidisciplinary care model for youth with lupus nephritis. Tell us a bit more about that model and the real kind of population management strategy for young people with lupus nephritis.
So the multi-D care model came out of an exercise to engage a whole bunch of stakeholders, including patients, caregivers, healthcare workers, advocacy groups, and also institutional leadership to figure out, what was most needed to help families through their lupus journey, and recognizing that gaps in care are really detrimental and that not every family can easily access follow-up care. We created systems to keep track of who the patients were and when they were needed to follow up so that we could intervene to ensure that follow-up actually happened. And to be honest, this started out as a relatively manual process for the multidisciplinary care model. And so it required a little bit of elbow grease. It's a color-coded Excel spreadsheet that Dr. Burnham and I reviewed and maintained on our own time. And scheduling needs were then communicated to sort of the administrative team once we figured out who needed to be in which one's clinic. And then our social worker would reach out to families ahead of time to address any potential barriers, such as transportation or work hours. And then eventually, there was a much more automated process using the electronic health record for other lupus patients where providers, nurses, and also admin staff could access a dashboard that showed, who was overdue for follow-up based on their last encounter date. So that was a little bit more less proactive because you essentially waited to see who was overdue for follow-up, whereas the multidisciplinary care model was proactive.
We'll cycle back to that for sure after we talk a little bit about the data in your manuscript. So in this manuscript, you report prospectively collected data from the CHOP Pediatric Lupus Research Registry and really focused on this unmet need of needing to develop better mechanisms to evaluate and measure programmatic interventions. Can you talk a little bit about the analysis and how you developed the kind of link to the EHR that allowed you to build this pediatric lupus research registry?
We generate so much data in the context of clinical care, and it just kills me that we haven't figured out good ways to leverage that information without sort of going cross-eyed with chart reviews when it's all electronic. There's no other industry where this happens. So building the research registry was really to address that pet peeve of mine. And it was also a two-step process. And the first step was just standardizing how we routinely document so that all of the relevant clinical information is discrete data. And that facilitates quality improvement efforts, but also facilitates research because the important information isn't buried in some free text. Now, I will admit, not everybody likes documenting that way. But by taking the second step to then use that discrete data, that all the clinicians put so much time into entering and making that available for research, I think helps demonstrate how worthwhile it is to change our documentation practices.
Oh, I completely agree. I think we've got to move to a situation where the computers work for us as opposed to us working for the computers.
Right.
And a big part of that is sort of harmonizing data collection into usable, meaningful fields. And so kudos to you and your team for getting that done. One of the interventions you study in this manuscript is a maintenance of certification intervention or mock intervention. There have been a lot of recent controversies about what mock and whether or not physicians should be expected to complete their mock activities while on vacation or in other settings. You specifically wanted to investigate whether a couple of programmatic changes impacted patient level measures of care delivery and clinical outcomes. Can you tell us about the design of the study? You have a beautiful flowchart graphic in the manuscript, but because this is an audio podcast, I'm wondering if you can talk us through it and give us a little bit more detail about the local mock activity that your providers participated in.
Sure. It was so this manuscript actually has sort of two separate studies that we packed in together with
Mhm.
overlapping time periods. The multidisciplinary care model was established first, and around the same time, almost simultaneously, to the standardized EHR documentation tools were built and rolled out across rheumatology, providing the infrastructure for measurement. And since not all young people with lupus nephritis were followed in the multi-D model, we were able to compare what happened to patients in each care context over the same period. So that was more kind of like a traditional cohort study.
Mhm.
The second study used a pre-post design, more similar to sort of QI projects to test whether motivating providers to utilize the PLCI that we already had at regular intervals to gauge their individual performance and sort of set goals for themselves actually improved the practice's average performance.
And improved at the level of the patient outcomes, right? So, what did you measure specifically in terms of outcomes and covariates for this study?
So we used the total PLCI score, which is a composite score, as the primary outcome. And since follow up is such an important care process, we also looked at timely follow up as a secondary outcome. And these are both all care processes. So we felt it was also important to include a clinical outcome. And for that, we used prednisone use versus non-use at any given visit. And covariates that we included were demographic information that was available in the EHR, major organ involvement as sort of indicators of how severe the disease was, and other sort of disease activity and treatment related factors that were allowed to change over time.
So, what did you find? Can you lead us through your results?
So, not surprisingly, we found that average PLCI performance or care quality adherence was better during the period when providers were asked to review their PLCI performance and set goals for themselves. Now, it was a small improvement, but measurable. And so, to give context, like before the goal setting activity was started, patients with lupus were already getting 70% of the recommended care processes in the PLCIs. So that's pretty good already. But then during the goal setting activity, that went up to 80%.
Mm-hmm.
Personally, I think the findings regarding the multidisciplinary care models are more interesting, but that might just be my personal bias. And so, receiving care for lupus nephritis in the multidisciplinary clinic at least once was, associated with an average completion of 88% of
Mm-hmm.
recommended care compared to 78% in the room clinic. And more importantly, patients with lupus nephritis were much more likely to attend their follow-up visits at the recommended intervals if they were cared for in the multi-D model, despite the fact that the demographic of the multi-D cohort was really, really skewed towards a higher percentage of patients who had public insurance or were Black race or Hispanic ethnicity compared to lupus nephritis patients who were followed in the general rheumatology clinic.
That's interesting. And we will definitely discuss that in a second. Tell me first, I don't want to miss this prednisone documentation issue. It was a bit of a surprise. And I wondered, could you tease out a little bit what you think could be the explanation? Do you think it was just clunkiness of EHR data? And how do you think that impacted the associations you saw between PLCI score and subsequent prednisone use?
So thank you for asking about that. Prednisone is like the wild, wild west of rheumatology. We just like can't get it right. And our inability to determine like how much prednisone someone's on at a given time messes up practically every type of lupusity you could think of. So we tried to solve that problem by building out prednisone dose as a discrete data field in
Mhm.
the EHR templates, but that also required providers to use the template and get through all of the fields. And the template was quite long, so not all of them got finished. And now the template itself sort of essentially prompts you to think about most of the care processes that are in the PLCI. So it wasn't surprising that PLCI scores were better for patients who had complete prednisone documentation.
Mhm.
Now, whether documentation practices themselves are also associated with prednisone prescribing practices isn't totally clear.
Mhm.
And so that's why we had to do a little bit of a sensitivity analysis to test the extremes in both directions.
Yeah, and I guess will forever be a challenge in our field, particularly with complex prednisone tapers and those types of things. It's just always hard to get clear information from a single time point documentation. So I'm curious also about the data that you showed correlating insurance type with prednisone use. Could you speak to that and give us your insights as a pediatrician? I was assuming that there's a relationship between DMARD access for those on public insurance plans. And it struck me that this might not be fixable by an individual provider and only fixable through advocacy on a larger scale for those kids. Could you comment about that issue?
Sure. So DMARD access might be one sort of component, but I don't think it's just that. I think it's reflective of access at all of the relevant points during which families need to interact with the healthcare system. And that can even include the diagnostic odyssey.
Hmm.
So, if it takes a child longer to get into rheumatology care, they're going to have worse disease by the time they show up and you start treating them. And then, I can't even tell you how many times I had to fill out extra forms for, children with New Jersey Medicaid, for example, just to come to rheumatology clinic and be seen.
Hmm.
And so So it's a hard problem to solve through advocacy as well, just because Medicaid and S-chip are administered so differently across states
Yeah.
that understanding the full impact is really complicated. And there hasn't really been a push to sort of centralize how that's done. So it's almost like you have to go at the state level one by one to sort of figure out what needs to happen to get these kids in.
Yeah. So actually, that brings me to my next question, because I wanted to spend a couple minutes emphasizing some of the unique features of the CHOP program and why some of these kids travel huge distances to come and see this particular lupus clinic. Because one of your strengths is this truly multidisciplinary team approach. I think in the manuscript, you say you have 2 rheumatologists, 2 nephrologists, a dedicated social worker, and a psychologist. And I can't help but notice that while that's a fabulous model that surely serves the kids that are coming to see that clinic, I can't help but acknowledge that access to clinics like this is impossible for many parts of the country. We in rheumatology, through the workforce study, have highlighted the vast unmet need for pediatric rheumatologists, and this understanding that we've come to that unless we develop new approaches for meeting this need, we would never be able to achieve and deliver the care that you outline in this manuscript. Reflecting on that, I have to think this is an adaptive challenge for the field of rheumatology that probably needs a different, more transformative approach. I'm kind of reminded of the poem by Portia Nelson, There's a Hole in My Sidewalk, because it's something we need as a community to acknowledge, kind of recognize that hole and find a new route to our destination. So, with that in mind, I'm actually curious to your point of view as a relatively younger pediatric rheumatologist. What attracted you to pediatric rheumatology when the sidewalk was so full of potholes? And second part of that question, how do you think some of the ideas and interventions that you tested in your study here could be scaled, particularly in the setting of a limited pediatric rheumatology workforce, and really improve healthcare delivery for kids with lupus nationally, not just locally?
Yeah, so I was a trainee that was interested in a lot of different things and like couldn't make up my mind. So I like the heart, I like the skin, I like thinking about the kidneys. And pediatric rheumatology was the one specialty where you got to do all of it. So it wasn't like by choosing one thing, I was closing other doors or giving something up. And so that's really cool. And I was fortunate that, my choice of subspecialty wasn't hampered by medical school debt. So thanks to Dr. Walter and Ann Gamble, who had the foresight to sort of put their philanthropy into addressing workforce shortages by making medical school more affordable. And essentially, they kind of filled that pothole for me in advance. And so I got to choose, whatever sparked the most joy. And
Yeah.
for that, I'm super grateful. And I recognize that, that doesn't help, it doesn't happen everywhere to everyone. But I think, medical schools are sort of moving towards that model. And certainly, NYU is sort of the first one to really, jump off that bridge. But, the workforce issue is definitely a big problem. And I think not as many trainees get exposed to pediatric rheumatology just because there are so few of us. So I
Mhm.
think, we really need to insert ourselves, into the general pediatric residency training programs and medical school training programs so that they can see how wonderful a specialty this is and how happy one can be doing this type of work. In terms of sort of scaling the interventions described here, I completely agree with you. Like the whole package is unlikely to be feasible everywhere. A lot of institutional support went into building it, and
Mhm.
not every institution can or is willing to put that dollar investment in. But if you think about it, it is in fact an investment. And if we can show that it's a worthwhile investment, then I think other centers would be much more likely to follow suit. And so there are already, other centers that are interested in implementing some of the EHR tools that we developed. And that's just sort of a first step in standardizing lupus care more nationally, but it's slow work, right? Like it's one by one,
Mhm.
a lot of blood, sweat, and tears that goes into sort of building this infrastructure everywhere.
Right. And really to scale to the whole country, you need more of a system level intervention, I'm assuming.
Right.
So, our audience also loves to hear a little bit about people's career crossroads. And you graduated fellowship, I think, in 2018
Mhm.
and have since become director of lupus research at the Boston's Children's Hospital and principal investigator of the lupus registry there. I wondered whether you could share with our listeners what you looked for in your first faculty appointment and how you evaluated your options at that transition point. And then a second part to that question, how did you make sure that you hit the ground running?
I knew I wanted a research position, so protected research time had to be number one on the list. And then, clinical research infrastructure was number two to support that research, and good collaborators and colleagues was sort of number three. But overhanging all of this was the fact that my spouse was also a surgeon, so it needed to be a city where he could get a job too. So we were kind of geographically restricted. Fortunately, I had an amazing research mentor, Dr. Pamela Weiss, who guided me through the whole process of making sure that I got grant funding so that no matter where I ended up, I could sort of hit the ground running.
Yeah, and then you've kind of maintained ties with CHOP all through that
Mhm.
process, and obviously even this manuscript is really using a lot of data from the CHOP registry. Are you able to talk a little bit about how to achieve that?
Yeah. So, I mean, I think the place where you train is like your first family, right?
Yeah.
And they will always be your first family. And then going somewhere new, you learn so much, new stuff. And so I think having been trained at one place and then now being in another place, I think that gave me a lot of opportunities to sort of build a network of people to work with
Mhm.
and then also data to use. And I think single center research is sort of going to die out soon, right? Like it's just not the way we should be doing things. So
Mhm.
trying to build those connections, I think between institutions is really important. So, like one of the projects we're working on right now uses data from both places. So I think that's really important. Like leveraging the expertise that we have at all different places around the country and sort of pooling that together really augments the work that we do.
Yeah, no, absolutely. And kind of that synergy allows you to do a lot more than you could alone. You have obviously been incredibly successful. You've accomplished a lot during those first few years on faculty. Do you have any tips for our listeners on how you choose to focus your efforts and what guides you as you figure out how to spend your time?
Sure. I try to do most of the quote unquote extra work in the evenings or on weekends, like things like reviewing papers for peer review or planning meetings or prepping talks or other administrative tasks. That way I can ensure that my typical workday sort of isn't cluttered with stuff that's not my primary research.
Hmm.
And then I also sort of try to separate clinical care work from research by blocking time out sort of in 2 to 3 hour chunks because you can't really get anything done if you're not like focusing on something for at least a 2 to 3 hour block. So that's sort of been my general strategy. The big caveat is like I don't have children,
Hmm.
so there's not this big sort of time sink that other people have to juggle. So I had the flexibility to kind of do it this way.
Yeah, yeah. As a pediatrician, you surely know children complicate everything. So I wanted to also take this opportunity to share a little bit of rheumatology history with our listeners. The Mary Betty Stevens Award that you received honors one of the great women of rheumatology, and I wanted to make sure our listeners are aware of the legacy. Mary Betty Stevens trained at Johns Hopkins and joined the Faculty of Medicine there in 1960. She was the first woman to head a Hopkins medicine division in the rheumatology division. And she directed the Hopkins Arthritis Center and the world-famous Hopkins Good Samaritan Rheumatic Disease Unit, which has sadly now been repurposed into other uses, but was for many years a very famous rheumatic disease inpatient unit. She was a devoted physician to her patients and an inspirational teacher who touched the careers of many. And as a recipient of the Mary Betty Stevens Young Investigator Award, Joyce, I wondered, how are you carrying that legacy forward?
Yeah, talk about imposter syndrome. I mean, it was such an honor, and at the same time, like sitting across the table from Joan Merrill and Eric Moran. I'm like, oh my gosh, I'm sitting across the table from Joan Merrill and Eric Moran. I think it just goes to show how heavily we are influenced by those who come before us.
Yeah.
I love teaching, so I really aspire to mentors for future pediatric rheumatologists and hopefully inspire a new generation of lupologists who also really love research. And so I think just passing it along and doing the work to make sure that young people have a path forward, I think is
Yeah, pay it forward. I love that. So, Joyce, thank you so much for sharing all your insights and experience with us today. Having you on the show has been a real treat, and I look forward to watching your career and seeing how you continue to make a difference for kids with lupus and for the pediatric rheumatology community. My shout out today goes to the giants of rheumatology history. They toiled at the bedside and bench and shaped many of the discoveries that drive care for patients with rheumatic diseases today. We all stand on the shoulders of these giants and carry their legacies forward as we impact the lives of those we serve. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at AC Room on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.